Start.
Ready, sir.
Hello everyone. Today we are going to discuss endometriosis in view of new guidelines, ESHRE guidelines, which have come in the month of February 2022. Old wine in new bottle, endometriosis revisited. I am Dr. Chaitanya Shambekar and I bring greetings from Omega Hospital, Nagpur. We are going to start this discussion, which is a case-based discussion on the management of endometriosis. As we all know, endometriosis is an enigmatic disorder, and as our circle of knowledge expands, so does the circumference of darkness surrounding it. What Einstein has said is so true for endometriosis. So, from where the tissue arises, what leads to progress, how it exerts impact is still not known, and that is why we say that it is an enigmatic disorder. But one thing is very clear, that endometriosis is a chronic inflammatory disorder where there is a presence of endometrium like tissue outside the uterus. It is estrogen dependent and mostly seen in reproductive age group, but may go beyond this age group, and you may get patients with menopause having endometriosis. If you look at the incidence of endometriosis, it is rising day by day. Initially, it was 170 million, now it is 190 million across the globe, with around 26 million patients seen in India. So, the India has got very high number of endometriosis patients. Endometriosis has got clinical impact in the form of pain and infertility. 2 to 10% of general population has endometriosis, and up to 50% of infertile women may have endometriosis. So the incidence is very high. Come 2022, and we are here with the new ESHRE guidelines on endometriosis, for which we have been waiting since long, because the last guidelines were there in 2014. So I must say that हुजूर आते आते बहुत देर कर दी, लेकिन देर आए पर दुरुस्त आए, ये भी कहना ज़रूरी है, क्योंकि there are so many things where they have changed the line of management. They have added so many new things which we are going to discuss today. We start with the case of Neha. Neha wants to know the exact diagnosis. She is a young professional, a 25-year-old, tall and beautiful lady with severe dysmenorrhea. She gets pain even after menses, and nobody is aware of this pain. She is popular in her profession. Marriage is on cards, but she is postponing marriage because of her pain. The problem with this pain is that it is not accepted by society unless it is in the connection with the physical injury. So if you get a fracture arm, सब लोग आपको पूछेंगे कि अरे कैसा हुआ, कहाँ गिर गया. फिर लोग पूछेंगे प्लास्टर कब निकलने वाला है. प्लास्टर निकलने के बाद लोग पूछेंगे फिजियोथेरेपी शुरू हुई क्या. And then when you are absolutely normal, all right, there is a sigh of relief. So this is a very typical picture of any physical injury. But this type of thing you never get in endometriosis, because a woman cannot discuss endometriosis over coffee or over lunch. That is the problem of endometriosis. As we know, endometriosis can be seen at various sites. Apart from the ovarian or the uterosacral ligaments, you may get it inside the uterus, which becomes an adenomyoma. You may get it in scar, that is a scar endometriosis. You may get it in, the patient may present with headache. Patient may have hemoptysis. She may come with catamenial pneumothorax. There may be hematuria, urgency of micturition, flank pains, constipation, diarrhea, or even hematochezia. So these are the various forms in which the patient might present with you. So you should have a high index of suspicion whenever you get a case of endometriosis. The question which arises is, can clinical symptoms predict the presence of endometriosis? And the answer is yes. The GDG recommends that clinicians should consider the diagnosis of endometriosis in individuals presenting with the following cyclical and non-cyclical signs and symptoms: dysmenorrhea, deep dyspareunia, dysuria, dyschezia, painful rectal bleeding, hematuria, shoulder tip pain, catamenial pneumothorax, cyclical cough, hemoptysis, chest pain, cyclical scar swelling pain, fatigability, and infertility. So, various symptoms and signs are seen, and it is so varied that you may miss endometriosis easily unless you have a strong and high index of suspicion. Another thing which is new in these guidelines is they have discussed about the apps, they have discussed about the questionnaire, and they have discussed about the diary. We always talk about empowering women to demonstrate their symptoms. So this is one of the methods of empowering women to demonstrate their symptom. What is the method? The method is to give them app, or to give them diary, or to give them questionnaire, which can actually benefit in complementing the traditional history taking process, and it aids in objectifying pain and empowering women to demonstrate their symptoms. So it is very clear that if you have something in addition to history taking, you are giving them enough time and opportunity to pen down, to write down, to discuss their problems so that the diagnosis becomes more easy and better. So, as I said, you need a high index of suspicion, and endometriosis should be considered a possible diagnosis in women presenting with such clinical symptoms, as it may result in an earlier diagnosis of endometriosis and in an improved quality of life for their patients. Because it is so clear that if you diagnose it early, it will directly improve the quality of life. So it has got an impact on quality of life. That is the reason why you should have this diagnosis in mind whenever patient comes to you with these symptoms. Next question is, how do you diagnose endometriosis? Now, as we are discussing a case of Neha, there are various methods of diagnosis. She is 25-year old girl who is not yet married. So traditionally, you avoid doing PV examination. But now the things are changing. One finger PV after talking to the patient, taking her consent is something which you can definitely do, because this PV examination helps you in better diagnosis of the endometriosis, especially in the diagnosis of endometriomas or ovarian tumors. So the question is, does clinical examination of symptomatic women reliably predict the presence of endometriosis? And answer is yes. Clinicians should perform clinical examination in all women suspected of endometriosis, although vaginal examination may be inappropriate for young girls without previous sexual intercourse. In such cases, you may do rectal examination, or you may do PR examination, or you may do PV examination gently after talking to the patient. Now, there is a prospective study which says that reliability of the clinical examination is improved if you do examination during menstruation. So we all know that the menstruation leads to increase symptoms, or the lesions, they also increase during menstruation, and therefore if you do clinical examination during menses, then you can diagnose it in a better way. So do examination and do it during menses. um, Another point is, suppose the clinical examination is normal, how do you respond to this? What do you do next? The guidelines say that even if the clinical examination is normal, you should move on and do imaging if you are suspecting endometriosis. So it is not that clinical examination is the end of the road. In fact, it is one of the methods of diagnosis, but you should actually go for diagnostic methods, modalities like imaging studies if you are not getting any symptoms. Now, as far as the diagnostic imaging techniques are concerned, there are two things which are stressed in the newer guidelines, and these are ultrasonography and MRI. Clinicians are recommended to use imaging in the form of ultrasonography or MRI in the diagnostic workup of endometriosis. But you should also be aware of the negative findings, and negative findings does not exclude endometriosis. Something which you all should know, that negative finding does not exclude endometriosis. Foxy has said that you should also do transabdominal sonography. And not only you should do transabdominal sonography, but you should also see the ureter and the hydronephrosis, kidneys, to find out the effect, the pressure effect of chocolate cyst or endometriosis on the ureter and the kidneys. Now, do you do TVS in case of Neha? Neha is unmarried. So we always think of avoiding TVS and doing PR examination. But there is strong recommendation in the new guidelines that transvaginal sonography is recommended to be used even in adolescents in whom it is appropriate. If it is appropriate, if you get the consent, if you explain the patient about the TVS examination, you should and you must do TVS examination, because TVS examination is something which gives you idea about so many things. It gives you idea about the location of the endometrioma, you get idea about the possibility of the adhesions, you get idea whether the hydrosalpinx is there. So many things you come to know. Adenomyosis you can diagnose. So TVS is the best, but if it is appropriate, you should do it even in patients of, with if even if they are not married, even if they are unmarried. And if a transvaginal scan is inappropriate or not appropriate, then what you can do is you can do MRI. Transperineal or transrectal scan may also be considered. So you can do transrectal sonography, but TVS in adolescents is allowed in the new guidelines. MRI. MRI is always considered as a second method because it is costly. But the new guidelines have said that an MRI should be done whenever possible. MRI is mentioned everywhere in 2022 guidelines. And they have said that MRI can actually replace the surgery as the gold standard for the diagnosis of ovarian endometrioma. So they have given so much of importance to MRI. So there is a strong recommendation for ultrasound as well as MRI. With the side, they have said that you should have a side note on false negative results as an alternative to laparoscopy, or as an adjunct to laparoscopy. You can do ultrasound along and as well as MRI. So MRI and ultrasound are given strong recommendation, but they have also said that there should be a side note about the possibility of the false negative results. You may get a results which are false negative. Now, very important point is laparoscopy. Till date, we have considered laparoscopy as a gold standard for the diagnosis of endometriosis. But how important is laparoscopy? There is a shift in the approach, and this is a 180 degrees turn, total shift in the approach. Laparoscopy is no longer considered as the diagnostic gold standard, and it is now only recommended in patients with negative imaging results and or where empirical treatment was unsuccessful or inappropriate. So if you think that you need to diagnose endometriosis if the imaging techniques are showing negative results, or if you find that the treatment is not proper, empirical treatment is not working, then only laparoscopy can be done. So you can offer laparoscopy, but it is no longer a gold standard for the diagnosis. And it is said that whenever you are doing laparoscopy, you must do histopathology, because histopathology should confirm the diagnosis. Although, again, negative histology does not entirely rule out the disease. So, negative histology may also be there even if the endometriosis is already present. Next in question is serum markers. And as far as the serum markers are concerned, there are so many serum markers which are available. CA125, CA19.9, IL6, all these markers we do for the diagnosis of laparoscopy, but the guidelines are clear and the message is loud and clear. Do not do serum biomarkers or endometrial tissue biomarkers or menstrual biomarkers to diagnose endometriosis. So the point is very clear. There is no role of CA125 for diagnosis of endometriosis. Foxy guidelines have said that you can do serum markers to rule out malignancies and as a method of follow-up of the treatment. There are there is a case report which has said that CA125 can be as high as 6,114 units in patient with benign endometrioma if there is a rupture of the capsule of the endometrioma. So if the capsule of the endometrioma gets ruptured, you may get very high levels of CA125 which may mislead you because you think in lines of malignancy, in line of ovarian tumor, malignant ovarian tumor, but this is because of the rupture of the chocolate cyst or endometrioma. ESHRE has given justification for not using CA125 as a method of diagnosis. They say that it is not used because negative result does not rule out diagnosis of endometriosis, and you may miss endometriosis because of the negative results. And if even if they are positive, they are irrelevant, they are not relevant, and they add to the anxiety, they may lead to over treatment, and that is the reason why they have said that CA125 should not be done for the diagnosis of endometriosis. Now we all know about the modified ASRM or revised ASRM guidelines, ASRM classification of endometriosis, where they have classified endometriosis into minimal, mild, moderate, and severe endometriosis, or they have done staging in the form of stage 1, stage 2, stage 3, or stage 4 endometriosis. This is a very extensive classification. I think in our day-to-day practice we do not do this classification, but this classification is something which can be actually, which should ideally be done. But frankly speaking, this is good only for examination purpose, where examiner may ask you some questions regarding ASRM classifications. Otherwise, in our day-to-day practice, it is our clinical acumen where we use this clinical acumen and we diagnose endometriosis from our clinical acumen. Now, how do we manage a case of endometriosis? The key question is, does laparoscopy compared to empirical medical treatment result in a better symptom management in women suspected of endometriosis? So we have two options. One is empirical management and second is doing laparoscopy followed by management. And the guidelines have said that there is a two-step approach, especially in cases of unmarried girls like Neha. We have a two-step approach that is also called as empirical treatment. So what they have suggested, do imaging first, give hormonal treatment as a first line treatment, be happy if the symptoms improve, presuming that it is endometriosis, and avoid laparoscopy. So, laparoscopy is no more a method of diagnosis of choice, but instead of laparoscopy, what you can do is you can give empirical treatment, and if the patient responds to the treatment, then there is actually no need of laparoscopy. Another thing which has come up now in a big way is fertility preservation. And in, especially in girls like Neha, who is unmarried girl, is endometriosis an indication for fertility preservation, ovarian tissue cryopreservation, or oocyte cryopreservation in unmarried girls? The guidelines say that in case of extensive ovarian endometriomas, clinicians should discuss pros and cons of fertility preservation with women with endometriosis. The true benefit of fertility preservation in women with endometriosis is not known. They have said that we really don't know whether it is really beneficial or not, but you must discuss because this is new. This is something which you should offer to your patients. In our center at Omega Hospital, we have many such patients who are unmarried, or who are planning to marry maybe in future, but they wish to cryopreserve their oocytes because they may think of pregnancy later in the age where it may not be possible to get the oocytes. Therefore, they are ready for oocyte preservation. The same thing is true with endometriosis, and therefore you may offer this treatment to your patients, but they are not very sure about the oocyte cryopreservation because they have said that there are many questions which still remain unanswered, like what is cost effectiveness, and is there currently there is a insufficient data about the use of fertility preservation techniques in patients with endometriosis, but this is something which can be discussed. What about long-term monitoring? Guidelines have not given any beneficial effect. They say that there is no evidence of beneficial effect of regular long-term monitoring of the patient of endometriosis for detection of recurrence, complications, or malignancy. And therefore, they have said that though there is no evidence of benefit, but you should do monitoring of the patient on an individualized basis, on the basis of previous and current treatments, on the basis of severity of the disease, and on the basis of symptoms. So you can do monitoring, but you know there is no clear cut guidelines about after how many days you should do follow up, after how many years you should do follow up. So it all depends on individualized basis. So you have to take the decision about whether you want to do it every yearly or every 6 monthly or every 2 yearly, depending on the situation. Now we come to the next case, and that is a case of Sheetal. So till now we have discussed about the new guidelines of endometriosis for the diagnosis of endometriosis. Now comes the management of endometriosis. And here comes a case of Sheetal. Sheetal is a homemaker, and her husband Satish is a banker. He's soft-spoken and caring husband. She is 26-year-old girl, married since 3 years, eager to conceive. She's trying since 2 years, but no conception. She has dysmenorrhea. She does not have dyspareunia. There is no male factor. Her AMH reports are normal. Her HSG shows patent tubes. There is no male factor, and ultrasound is normal. How do you manage this case? How do you proceed? Can you consider diagnosis of endometriosis even if clinical examination is normal? Yes, the guidelines have clearly said that even if clinical examination is normal, the symptoms of endometriosis you can think of endometriosis because you need a high index of suspicion for the diagnosis of endometriosis. Suppose this patient, she is married since 3 years, her AMH is 2.1. You wish to proceed further, you may think of doing laparoscopy in this patient. In case of Neha, there was no role of laparoscopy because she was unmarried girl. So in an unmarried girl, laparoscopy is not used for the diagnosis. But the guidelines have said that if you are getting a case of infertility, and if you wish to do the tubal patency, and if you wish to see the other factors, then you may do operative laparoscopy. There is no role of diagnostic laparoscopy, but operative laparoscopy and surgery like adhesiolysis or ablation of the fulguration of the endometrial lesions is something which is advised if you are having problem with the endometriosis and infertility. So this is something which is clearly mentioned in the guidelines. Laparoscopy is done. There is grade 1 endometriosis. We have done her fulguration. It is said that operative laparoscopy could be offered as a treatment of endometriosis associated with infertility in stage 1 and stage 2, as it improves the ongoing pregnancy rate. So in case of Sheetal, she is having mild endometriosis. There is some endometriotic spot which is seen, fulguration done, and you have offered her laparoscopy. Clinicians may consider operative laparoscopy for the treatment of endometrioma associated with infertility, as it may increase the chance of natural pregnancy, although no data from comparative studies exist. This is a weak recommendation. So if you have a moderate or severe endometriosis or a chocolate cyst, guidelines say that you may do laparoscopy in such patients, but the studies do not exist. In mild endometriosis, it helps. In moderate to severe endometriosis, also it helps. You all should know what is endometriosis fertility index. Endometriosis fertility index is of great value in the diagnosis of endometriosis and especially in the management of endometriosis to know the possible options available for any given patient. So when you put a scope, you see tubes, you see fimbria, and you see the ovary. In tubes, you have to see whether there is a slight injury, or there is moderate injury, or there is a severe problem with tubes, or the tubes are not functional. So they have mild, moderate, severe, and non-functional, four categories of tubes. In fimbria, you have to again see whether there is a slight injury to the fimbria, or the fimbria are moderately injured, or severe injury, or non-functional. So this is the second thing. See the tubes, see the fimbria. Then third thing you have to see is see the ovary. And the ovary again there are mild, moderate, severe, and non-functional ovary where the ovary is completely absent or it is completely encased in the adhesions. So depending on the severity of the problem, you can see the tube, the fimbria, and the ovary and categorize the patient into mild, moderate, severe, and non-functional categories. Similarly, you have to take the history of the patient. So historical aspects and combine the historical aspects and the laparoscopic aspects. And this ultimately gives you the EFI or endometriosis fertility index. And this EFI score is from 0 to 10. 0 is having poorest prognosis and 10 is having best prognosis. So suppose you have your patient with some particular score, then you can definitely discuss with her and her partner about the mode of treatment or the management depending on the score. And this is exactly what we have done in our MUHS fellowship thesis, which was done by Dr. Parul Savji. What we tried to do is we recruited 28 women for endometriosis fertility index. We have done EFI of 28 women. We found that natural conception was possible if the EFI is 6 to 10. If they have 4 to 5 EFI, then ART is offered. And if the EFI is 0 to 3, they are counseled strongly for ART for IVF. So if you know her AFI, you can work as a part-time palmist and you can also predict the fertility of your patient. That is exactly what we have done in our thesis on EFI and its role in the management of endometriosis associated with infertility. Now, for the first time, this guideline has a clear-cut mention about EFI. They have said that women should be counseled for the chances of becoming pregnant after surgery, to identify the patients that may benefit from ART after surgery. EFI should be used as a validated, reproducible, and cost effective method. The results of other fertility investigations, such as their partner's sperm analysis, should be taken into consideration. So they have given the importance to EFI. They have said that EFI is validated, reproducible, and cost-effective method of prognosis explanation to the patient. We can, of course, think of giving antibiotics and probiotics in patient of endometriosis because it is very clear that endometriosis is actually an inflammatory disorder. So probiotics, in addition to metronidazole, can also be given. There is an ongoing endometriosis research in India, and this is called as ECGRI, Endometriosis Clinical and Genetic Research in India, and this is conducted by ICMR under the leadership of Dr. Smita Mahalle as a supervisor, Professor Grant Montgomery as mentor, and our friend Dr. Rahul Gajbie is PI of this clinical trial, and I am very proud to mention you about our role in this ICMR study. Omega Hospital is one of the centers. There are only 7 to 8 centers all over India, which includes AIMS Raipur, Lucknow Medical College, and other medical colleges all over India, and Omega Hospital is one of the centers. And till now, given 93 cases for we have given 93 cases for this research from Omega Hospital, which is second highest number after Manipal. And this is really a big achievement. With the blessings of everybody, we have been able to achieve this, and our name has appeared in British Medical Journal, which is an international journal, because they have actually published this study. And this study is an ongoing study which will continue to take place over the period of next 5 years. And I am very proud to mention here that Omega Hospital is playing a crucial role for this study. So coming back to a case of Sheetal. Now Sheetal is a case of mild endometriosis. We have done a laparoscopy. Once the laparoscopy was done, immediately the relatives they started asking me question that when are you going to give us result? We want baby. So I asked them, please give me 2 to 3 months and I'll do something for you. So what is the next step? Next step is of course IUI. IUI is on cards and IUI is the next step. And the guidelines say that in patients with stage 1, stage 2 endometriosis, clinicians can perform IUI with ovarian stimulation instead of simple treatment. So IUI is preferred over simple treatment, and therefore we can give IUI in this patient. And it is said that we should do it within 6 months. So you can immediately start and use IUI as next method of treatment. And again, once again, they have said that there is a value of EFI to predict the relevance of IUI and whether the IUI is a good treatment option or not can be decided from the EFI. So EFI is a good method for decision making in IUI. In IUI, you can try IUI in mild, moderate, or severe endometriosis, but it is said that in stage 1, stage 2 endometriosis, IUI gives you good results along with ovarian stimulation, but IUI can also be considered in stage 3 and stage 4 endometriosis. You can try IUI in stage 3, stage 4 endometriosis as well. The only problem is that the success rate of IUI is very low if you do IUI in moderate to severe endometriosis. Otherwise, in mild to moderate endometriosis, the results are good. How do we do IUI? Definitely, we have to do IUI with ovarian stimulation. And you must give gonadotropins to the patients. Unless you give gonadotropins, you will not get success. And it is said that gonadotropins are gonadotropins are gonadotropins. And any gonadotropin, FSH or HMG, can be given for the treatment in case of IUI. What about antagonist? Antagonists have no role to play except for cycle scheduling. Suppose you want to avoid weekends or if the patient wants to avoid some days, then you may give antagonist. Otherwise, antagonist has no role to play in IUI. How many cycles of IUI? Nowadays, only 3 cycles, or even sometimes only 2 cycles. Though optimum number is 4 if the patient is young, like if the patient is 28, you may go for 4 cycles. But more and more studies are coming which say that you should not do more than 3 cycles of IUI. It depends on age, anxiety, and associated factors. So in case of Sheetal, you may go for 4 IUI, but better to go for only 3 IUI. And which drug you will use if you want to give oral ovarian stimulation agent? It is letrozole. And letrozole is considered as the best drug. And all studies have said that they have impact on the endometrium also. They are aromatase inhibitors, therefore they should be given as a treatment of choice for ovulation induction. Luckily, our patient Sheetal conceived after 2 IUI, and therefore there was no need to go for IVF. Otherwise, we would have gone for IVF also. So Sheetal was lucky. Sheetal got response in 2 cycles. But I will discuss you the last case, and that is the case of Karuna. Karuna is not so lucky. Karuna is married since 10 years. Her age is 34 years. Her first laparoscopy was done 8 years back, where there was a chocolate cyst with adhesions. Lupred was given during that time after surgery. Then IUI was done 6 times. Remember, 6 times IUI. And then there is again a recurrence of cyst with 5 centimeter cyst which is seen. Our AMH now is only 1.2, it has gone down. So what is the plan of action? It is said that first surgery should be the last surgery in case of endometriosis. Remember friends, this is the tagline and the dialogue which you all should keep in mind, that in endometriosis, first surgery should always be the last surgery. Because if the surgeon is not competent enough, if he is not doing good cystectomy, if he is some remnant endometriotic tissue is still there, then the chances of recurrence are very high. And therefore, first surgery should be done by a good surgeon, a skillful surgeon, and it should be the last surgery. In case of low AFI with severe endometriosis, associated factors if it is there, or if IUI has failed, then their guidelines clearly say that you can go for ART. So in case of Karuna, you can definitely go for ART, that is IVF. So IVF is the next treatment of choice if the patient has got severe endometriosis, if IUI has failed, or if they have associated factors. We do TVS before going for IVF, and this TVS is a simple investigation which gives you idea about so many things. If there is a chocolate cyst, what is the location of the endometrioma? Is there any hydrosalpinx? Is there any adenomyosis? Will you be able to do ovum pickup easily? Accessibility of the follicles, endometrial vascularity, endometrial thickness. So many things you come to know from TVS examination. So TVS is a very important examination. And you identify the ovaries, you see the endometrioma, you see the ovarian reserve, you see antral follicle count, and you also evaluate the endometrial receptivity. After doing this, whether to go for surgery or not is the question. And it is very clear, friends, that clinicians are not recommended to perform surgery before IVF to improve the success rate. In fact, it is the other way around. It is said that this surgery will not only damage the ovarian reserve, it will also reduce the ovarian reserve, and therefore the guidelines clearly say that if at all you are doing endometrial surgery for endometriosis associated pain, in that case you have to do the counseling of the relatives and the patient that this surgery might reduce the ovarian reserve. So what are the only two indications for surgery? One is for the relief of pain, even if the patient has got infertility, and second is to improve the accessibility of the ovarian follicles by doing some adhesive. So if the ovaries are impacted into the pelvis, and if you feel that the pickup may be difficult, in that case you can do endometriosis surgery. So laparoscopy is indicated in only two things: severe pain and to improve the accessibility of the ovarian follicles. So to do or not to do, that is the question, and the answer is not to do. If at all you do, then you which type of surgery you should do? Cystectomy, not just a drainage of cyst, but cystectomy, because cystectomy gives you better result. The chance of recurrence are low. Clinicians are not recommended to routinely perform laparoscopy for ovarian endometrioma, and the current evidence show no benefit, and surgery is likely to have negative impact on the ovarian reserve. Therefore, laparoscopy should not be done as far as possible in the patients of IVF before IVF. Only indication is pain or accessibility of follicles. So it is very clear that you should not do laparoscopy. Even if the patient has got deep endometriotic infiltration or deep infiltrating endometriosis, it is better to avoid laparoscopy except for pain. So patient preference, lack of RCTs, only for pain you can do, otherwise you should not do. Once you do cystectomy, suppose you do cystectomy and you are planning IVF, when should you do IVF? Whether you do it immediately or you give leupride injection for 3 to 6 months and then do IVF? This is very interesting. 2014 study or 2014 guidelines, they have quoted Salam et al. And this Salam et al. In 2006 has said that 3 to 6 months of leuprad agonist or GnRH agonist treatment after surgery improves pregnancy rate 4 times. 4 times. Imagine. So it was said to be the best treatment, and that is exactly what we used to do. We used to do surgery, then we used to give leupride depot, and then we used to take the patient for IVF. Now, 2022 guidelines, there is a complete U-turn. There is a complete U-turn, and it is clearly mentioned. This is a major change. Remember, friends, this is a major change. They have clearly said that the extended administration of GnRH agonist prior to ART to improve live birth rate in infertile women with endometriosis is not recommended. Not recommended, as the benefit is uncertain. In fact, try to understand. This is very logical. Try to understand this. If you are stimulating the ovaries to get the oocytes, why do you want to suppress the ovaries before stimulation? If you suppress the ovaries for 3 to 6 months before stimulation, what will happen? You will not get oocytes at all, or you will get very few oocytes. So this is something which you don't want to do. So major change in the guidelines. Now, post-operative agonist treatment is not recommended in patients with infertility. So this is what is the contrast. In contrast to the updated version, this Cochrane review, it is said that it is uncertain and therefore it should not be done. So very clear. Uh, there is some role of agonist, some role, though uncertain. People say that it has got its impact on the endometrium, and you may get a good endometrium with agonist treatment. So what we can do now, because that time freeze all policy was not available. Now we have this very excellent facility of freeze all policy. So what you can do is you can plan surgery. Immediately after surgery, you do ovum pickup and do embryo freezing. Then give 3 to 6 months of leuprad agonist, and after giving GnRH agonist for 3 to 6 months, you can do transfer. So embryo transfer can be done after giving agonist. This can help in improvement of pain and also may give you good endometrium for good implantation. So how do you plan? First do surgery, then do pickup, do embryo freezing or cryopreservation, then do give 3 months of agonist treatment, and then plan FET or frozen embryo transfer. That is how you go. As far as protocols are concerned, it is said that no protocol has got a benefit. Agonist and antagonist, they are same, but then antagonist is better than agonist. As far as the gonadotropins are concerned, guidelines say that you can give any gonadotropin, HMG or REC-FSH. You can give agonist or antagonist. Both can be offered because there is no difference. It's an individual choice. Does ART has any effect on endometriosis? Women with endometriosis can be reassured regarding the safety of ART, since the recurrence rates are not increased compared to those women not undergoing ART. Because you may get some patients may come to you, your OPD, and they may ask you that, doctor, it's okay, you are doing ART for me, but what about the effect of ART on my endometriosis? Will it increase in size? You have to say, reassure her that it has got no effect. Therefore, you must reassure her that you can do ART. You have to counsel this patient that ART is not going to have any bad effect or bad impact on endometriosis size or progression of the disease. As far as the ovum pickup is concerned, whenever you are planning ovum pickup, you have to remember few things. Never ever go inside the endometrioma. because if you puncture the endometrioma, then there is a possibility of infection. It may lead to ovarian abscess, and this ovarian abscess is really difficult to treat. It will, आपको भगवान याद आ जाएंगे. Treatment becomes very difficult. So please avoid puncturing the endometriotic cyst or a chocolate cyst. One thing. And second thing is, if at all accidentally you puncture the cyst, you change the needle. Third thing, use antibiotic prophylaxis in all patients with endometriomas. So whenever you're doing pickup, you should do and give antibiotic prophylaxis. So the guidelines say that in women with endometrioma, clinician may use antibiotic prophylaxis at the time of oocyte retrieval, although the risk of ovarian abscess formation following follicle aspiration is low. It is low, but it is there. But that ovarian abscess is really difficult to treat, and therefore you should never get this in your clinical practice. Never ever you should encounter ovarian abscess in your clinical practice. Whenever we are doing embryo transfer, we have to keep in mind that ET is difficult in adenomyosis and endometriosis. The uterus is retroverted, the cavity is deviated, so you must do mock ET first. You must give this patient etosiban or some drugs which can help you in uterine relaxation, and you must do it carefully. So embryo transfer is not very easy in patients with endometriosis. You should be very careful, and it should always be done by an expert IVF consultant. As far as the endometrial support is concerned, dydrogesterone is a good drug because it has got an immunomodulator function. And because of the immunomodulation, there are many studies, especially B.N. Chakravarti et al. Have done many studies on the role of dydrogesterone in patients with endometriosis. And it is clear now that dydrogesterone is a better drug for endometrial support because it will improve the endometrial thickness, and it is better because of the immunomodulator action of this drug. Non-medical strategies should not be given because they do not have any role. So things like nutrition, Chinese treatment, electrotherapy, acupuncture, physiotherapy does not have any role, and the benefits are not there. So this is the picture of uterus of Karuna, which was taken during C-section. And happy days are here again in the life of Karuna. Karuna has delivered a baby girl in our Omega hospital after proper management of Karuna, which was a case of recurrence of chocolate cyst of endometriosis with severe endometriosis with endometrioma, married since so many years, but ultimately was treated very nicely with IVF, and she delivered a baby girl. So all is well, that ends well. This is the picture which you can see here. Still there is adhesion. Still you can see a small endometriotic nodule over here. You can see classical endometriosis on the ovary also, but by the grace of God, she conceived, and now she is happy with her baby girl. These are the major changes in the guidelines 2014 to 2022. First major change is laparoscopy is no more considered as the gold standard. Second major change is danazol is no more considered as a treatment. It is discarded from the treatment of medical management of endometriosis. Third thing is that they have also no longer given ultra long agonist protocol for patient with endometriosis. You should not give 3 to 6 months of endometriosis agonist protocol for endometriosis. It is again discarded. Then they have given a separate chapter on recurrence of endometriosis. They have given a separate chapter on endometriosis and adolescence, a separate chapter on endometriosis and menopause. They have also discussed asymptomatic endometriosis, and they have discussed extrapelvic endometriosis, and they have also discussed endometriosis and cancer. So these are the new additions which or new changes which are there in the guidelines of 2022 ESHRE guidelines for endometriosis. So these women are given life sentence and are trapped by endometriosis. These are the words of Dr. Louis Broderson written in 1776, which are so true even today. Following a diagnosis of this endometriosis, Many women are subjected to roller coaster of hit and miss treatment and subsequent impact on the quality of life. When I was surfing on Google, I found this statement, which is really very, you know, touching and something which you start thinking about. One woman with endometriosis expressed, when you are healthy, you have many dreams. When you are healthy, you have many dreams. But when you are ill, you have just one. And the dream is to come out of that illness. So true with endometriosis. So, what you need is empathy. And if you consider your patients empathetically, if you give proper treatment to them, then they are definitely going to get results. And that is all what I wanted to discuss with you. So these are the 2022 guidelines of ESHRE, and we have discussed three cases based on the changes which have taken place in the management of endometriosis. And I thank you all for patient listening. Thank you very much.